morning, everyone. My topic is on surgery in thoracic lumbar TV spine, principles of management. The primary goals of treatment of TV spine is to eradicate the disease, to prevent the deformity, and to restore and preserve the neurological function. We all know that chemotherapy is the mainstay of treatment. It does help to eradicate the disease, but it definitely does not help to prevent the progression of deformity. So the surgical indications include lack of response to chemotherapy at least for 6 weeks. If the patient has a progressive or profound neurological deficit, if the patient has established or progressive deformity, and of course to shorten the duration of symptoms. The surgery can be as simple as abscess drainage, or it can be radical in the form of debridement or stabilization, which can be performed anteriorly, posteriorly, or combined. This is an example in 30-year-old man with L1, L2 TB, where the body height is very well maintained, though the MRI has shown a significant destruction with bilateral paravertebral abscess. This patient was managed with ultrasound-guided aspiration of the pus, and he was started on chemotherapy. And 1 year follow-up, he has completely healed tuberculosis with no deformity. We used to do anterior surgery once upon a time, but this anterior approach is associated with significant morbidity, which can be now performed all posteriorly. If the bottle body height is maintained, though the MRI shows a significant bottle body destruction, it can be managed only with posterior stabilization. Whereas if the bottle body height is reduced more than 50% and it shows a significant destruction, only posterior stabilization would lead to instrumentation failure. In such conditions, it is always recommended to reconstruct anteriorly and stabilize posteriorly. And of course, if there is established deformity, then anterior reconstruction and posterior stabilization is always recommended. This is our own classification of treatment of TV spine, where we have classified into uncomplicated, complicated, and complex. In uncomplicated, the patient will have a pain, but neurology is normal without any obvious clinical deformity. And radiologically, it has shown a intact bottle body height, or the bottle body destruction is less than 50%. In such conditions, a trial of conservative treatment for 6 weeks is given. If it is not responding, then simple abscess drainage or posterior one instrumentation would suffice. If there is a deformity, obvious clinical deformity, then in such conditions, the anterior debridement and anterior reconstruction with posterior stabilization is recommended. In complex, the patient will have a neurological deficit with or without deformity. If there is no deformity, which is type A, then just the drainage of the epidural abscess with posterior stabilization would suffice. In case of the presence of deformity, then anterior debridement, reconstruction, and posterior stabilization is recommended. Thank you all for your